I'm Kezia. I'm one of the IMT2 trainees at Conquest Hospital. Today, I'm going to present on oncology presentations. It's mainly that what we used to see on the Acute take. I'm with my Acute oncology colleagues as well, and they're also, I think, they've joined for today's meeting, and they will be sharing their experiences or something from their practice after my presentation. So I think I'm going to start. Um, oh, this is not moving. Yeah. So it's just the first slide is just about some statistics. So from my experience, I can say when we are doing acute take daily basis, we might see maybe 1 or 2 cases per day who are coming with oncology emergencies. Either it could be a neutropenic sepsis or someone coming with malignant hypercalcemia or someone who is there for drain. So we used to see quite often the people are coming with oncology emergencies. So the main key is it's prompt and timely management of oncology emergencies is very important because it can reduce the length of hospital stay and morbidity. So time is the key. One of the reasons why we are doing this presentation today is our oncology colleagues have done some audit and they have found out, like, at the moment, the way we are treating needs a little bit more, like the time and everything that need to there should be some changes. So that's one of the reasons that we are doing this presentation today. So time is the key. So the next one, these are the topics that I'm going to cover today. It's few of the oncology emergencies. It's neutropenic sepsis, scod compression, metastasis, intracranial metastasis, superior vena cava obstruction, malignant hypercalcemia, diarrhea, pneumonitis, malignancy of unknown origin, chest pain, and dyspnea. No need to worry, I will be so quick. I'll just brushing up only the topics. So no need to be worried about this much topics that I've put on the screen. So these are the topics that are not covered in this presentation, mainly the immune therapy related toxicities and tumor lysis syndromes, and something that the oncology team will be dealing in the community: nausea, vomiting, some allergic reactions. So this is just a case. Actually, this is not some difficult case or something interesting. It's just something that we used to see every day. The why I put this case on today's presentation is mainly for like an introduction to the topic. So this is a patient who was presented to our hospital at Conquest, a 68-year-old female who was admitted on 10th of February, who has a past medical history of AML with MDS changes, who has completed their 4th cycle of chemotherapy on 19th of Jan, who doesn't have any allergies, performance status of 80, presented with lethargy, fever, dry cough, increased urinary frequency for 4 weeks. On observation, the temperature was 38.1, slightly tachycardic, but otherwise the observations are stable. So what would you do? So mainly why I asked that question is, here, this is actually, we all know this is the neutropenic sepsis that we are dealing here, because suspected neutropenic sepsis, because the patient had a chemotherapy recently and is coming with a temperature spike. The main point that I have to emphasize here is the treatment that we should be giving within 1 hour. The patient should be receiving empirical antibiotics within 1 hour. That's so important. That's one of the things that been found out in the audit, that sometimes when someone coming to the A&E, they are not receiving their antibiotics, empirical antibiotics, in the right time, and that's causing problems like severe sepsis and sometimes needs intensive care admission and everything. So it's very important. So someone presenting like this, for next we need to do the examination, then blood culture including from all the lines the patient has. Then we should be starting the empirical antibiotics within 60 minutes. We should not be waiting, no need to wait for the blood results to come back. So likewise, the patient received the antibiotics. We have done the bloods. The bloods are back with neutrophil counts of 0.03. Chest X-ray, urine was normal. Blood culture, which was done on 10th, showed E. coli, which is sensitive to tazocin. So we continued the tazocin. Then later on, we added some antifungal as per the micro advice. The patient was given some GCCF. Actually, this is in some malignancies, it's been contraindicated. So this should be either an acute oncology or the specialist advice. Then the patient had a blood culture on 17th, which was negative. So we have discharged the patient with oral antibiotics and antifungal. So I've just prepared a small chart about the neutropenic sepsis. Hopefully this would be helpful for the junior doctors. It's mainly showing how important that we need to give the patients antibiotic within 16 minutes. So someone coming with suspected neutropenic sepsis, when we say it's suspected, means the patient had chemo in last 6 weeks with a temperature spike more than 38 or more than 37.5 on two separate readings, and or the patient is clinically unwell or any red or amber flag signs. The patient should be urgently triaged and assessed. History, then we need to take the history. On the history, the one of the point that's very important is the date of the last chemo or radio regimen. We have to examine the patient, need to do blood cultures from every lines, lactate. Then empirical antibiotics should be started without waiting for the results. And we need to contact the acute oncology team. Then when we admit the patient, the side room is advisable. If there is any signs of severe sepsis, we need to contact the intensive care unit. If the patient has a diagnosis of cancer, that does not preclude the patient from intensive care unit assessment. So patient should be having the intensive care unit assessment if the patient having severe sepsis or clinically really unwell. So, so the point that I want to emphasize is the management should be in 60 minutes. Then if the patient has a confirmed neutropenia, then the patient will be admitted with the confirmed neutropenia means neutrophil count of less than 1. Then we need to consider GCCF, continue antibiotics unless sensitivities from the culture. Then we can consider switching to oral and home if clinical and social circumstances allows after 48 hours. If the patient is deteriorating after 48 hours, then we can consider second line antibiotics after discussing the micro. If they're deteriorating again after 96 hours, can consider antifungal after discussing the micro and treating consultant. So that's all about the neutropenic sepsis. I'm going to move to my second case. This is a 66-year-old man who was actually admitted to the Eastbourne with a past medical history of metastatic cancer prostate, which was diagnosed in 2017. The patient had chemotherapy. At the moment, patient is on LHRH and awaiting review from the clinical trial. No drug allergies, performance status of 60. Patient presented with acutely worsening and progressing back pain for 1 week, radiating down to left leg with limiting mobility. Observation stable on examination, power intact in all 4 limbs, gait limited by back pain, that's a normal. What would you do? So here actually, we all know what the diagnosis is. Probably it's a metastatic spinal cord compression. So the things that we need to do is we need to contact the acute oncology team, start on dexamethasone with a PPI cover and urgent whole spine MRI within 24 hours. So the patient had an urgent MRI whole spine on 7th of February and which showed metastatic spinal cord compression at T12 with lesions on T9, T11 and T12. The patient had radiotherapy on 8th of February and then we continue with PPI, DEX with PPI cover and analgesic. This is a little bit a complicated case because the patient was presented again with the same problems on March 3rd. And was difficult to control the pain. So again, the patient was after an MRI whole spine, patient was been referred to the radiotherapy. I don't want to go into the details of that. So at the moment, I've just created like a small diagram for the junior doctors to have a look how we need to manage. I know we all know how to do, but just like a reminder, what is a metastatic spinal cord compression? It's a pathological vertebral body collapse or direct tumor growth causing compression of the spinal cord. Irreversible neurological damage ensues with resulting paraplegia. So someone who is non-diagnosis or history or suspected cancer who is coming with back pain, the patient need an immediate assessment and patient need an urgent whole MRI spine within 24 hours. So from the history, sometimes we can get clue, back pain, which is new onset, worsening chronic back pain or worsening on walking, nocturnal spinal pain, aggravated by coughing or sneezing, radicular pain, or the patient present with limb weakness, sensory loss, bladder or bowel dysfunction, or off legs. So once if the MRI confirmed the metastatic spinal cord compression, the patient should be urgently discussed with clinical oncologist, consultant neuro or spinal surgeon, or where possible, the treating oncology consultant prior to definitive treatment decisions. Start on the dexamethasone with PPI cover. Usually we'd start with 8 milligram BD, then analgesic and thromboprophylaxis. Then we need to withhold the chemotherapy, including oral therapy, until the discussion with the AIS or specific team. and consider discharge. Actually, this is up to the specialist advice. If it's grade 1 no focal neurology, maybe we can consider MRI whole spine within 1 week and can discharge with pain control, and the oncology team has to follow up the patient maybe on the daily or 2 daily basis to check upon the symptoms. But that's like a specialist decision. Otherwise, our job is to arrange an urgent MRI spine within 24 hours and cover with DEXA and PPI cover. The the next one is intracranial metastasis. So sometimes we used to see this patient. It's usually the lung cancer is the one with having the most brain metastasis. It's more 50 percentage. Other ones are breast, unknown primary, melanoma. So usually the presenting complaint would be headache, nausea and vomiting, confusion, seizure, some focal neurology, or this would be new onset, subacute or progressive. So routine investigations we have to do. Then the ideal one, the diagnostic one is CT head with contrast. Sometimes MRI brain is indicated if CT head is normal but highly suspicious from the clinical history, or equivocal if there is multiple metastasis. Here also we need to start on dexamethasone with PPI cover. If the patient is present with seizure, we need to give anti-epileptics, anti-emetics, and analgesics. Indications for urgent neurosurgery referral: if there is hydrocephalus, mass effect or midline shift, acute hemorrhage, if there is a suspicion of abscess, or posterior fossa or midline or third ventricular tumor, or deteriorating GCS. If GCS is less than 12, we need to let the intensive care unit know about that, and the patient needed urgent neurosurgery referral, and the patient should be kept nil by mouth. So this is if it's a new diagnosis, there is no other diagnosis of malignancy or anything, we need to assess the performance status for the further treatment, staging CT, tumor markers, refer for neurosurgery, MDT, or cancer of unknown origin, MDT. But this all acute oncology team can help us out with how to proceed. If it's non-primary with brain metastasis, then it's a discussion in the MDT. Sometimes if it's a poor performance status or advanced disease, or for symptom control, we need to refer to the palliative team. And if can consider sometimes discharge, but it's also as per specialist advice or decision. If the patient is fully functional and with minor neurology, then sometimes we can consider discharge with oncology follow-up and safety netting. So the fourth one is superior vena cava obstruction. So it's obstruction of the blood flow caused by external pressure or tumor inversion and blood clot. It's nearly always malignancy. Lung cancer is the most one. Otherwise, maybe other lymphoma, breast cancer, or germ cell tumors. But there are non-malignant causes like pericarditis, aneurysm, or goiter. Usually the symptoms are dyspnea, chest pain, cough, facial and neck swelling, trunk and arm swelling, dizziness, headache, syncope, confusion. The investigation in all the routine investigations, including chest X-ray, which can show the mediastinal widening or mass. Then we need to do a CT thorax and all the bloods. The signs would be facial and conjunctival edema, dilated veins, tachypnea, cyanosis, arm edema, plethora, or vocal cord paralysis. The management is sit up the patient, oxygen, analgesia, and here also it's dexamethasone with PPI cover. And it's definitive management stenting. Percutaneous placement of a self-expanding stent gives rapid symptomatic relief in more than 95% of patient, and for that we need to discuss with interventional radiologist or cardiothoracic team. If the cancer is a new diagnosis, consider biopsy for the histological confirmation. Sometimes stenting won't be feasible, then we need to do radiotherapy, and chemotherapy is indicated for the patients with lymphoma or small cell cancer. If there is any thrombus present, then we need to consider anticoagulation if no contraindication, and we need to withhold the chemotherapy medication. Next one is malignant hypercalcemia. This is one of the presentations that we used to see quite often. So malignant hypercalcemia means corrected serum calcium more than 2.6. It's in advanced malignancy and in multiple myeloma, breast, lung, or renal cancer. So the main presentation, it can be with anything. GI presentation like anorexia, nausea and vomiting, constipation, abdominal pain, sometimes with renal, polyuria, polydipsia, dehydration. cardiac, some arrhythmias and ECG changes, CNS, fatigue, lethargy, headache, confusion. I'm going a bit fast because I know these are like a common things we all know about, and it's just a reminder. Then the routine investigations, if it's not known to have any active malignancy, we need to add PTH, cortisol, ESR, TFT, vitamin D, myeloma screen, LDH, and endocrinology review. Then we need to know if the corrected calcium is more than 2.9 and symptomatic, we need to admit the patient. We need to review medication that can cause hypercalcemia. So the main point is rehydration. It's 3 to 4 liters per 24 hours of 0.9% saline. We need to do daily bloods, including other electrolytes, because hypercalcemia can cause hypomagnesemia and hypokalemia. So we need to do that. Then if there is a renal failure, we need to consider dialysis. If the corrected calcium is 2.9 and the patient is not that symptomatic, maybe we can discharge the patient, but we need to discuss with acute oncology team and the patient's own oncologist if possible. If it's second or subsequent episode of hypercalcemia and the presentation calcium is more than 2.9, consider bisphosphonates post rehydration, either pamidronate or solidronate. But if we need to arrange if it's low EGFR. The next common presentation is diarrhea. Diarrhea, it's mainly, there are a lot of differentials for the diarrhea, but if someone coming with after the chemotherapy, then we need to think about chemotherapy induced diarrhea. It's mainly usually the agents which can cause diarrhea: capecitabine, 5-fluorouracil, irinotecan, erlotinib, afatinib, and pemetrexed. Radiotherapy to abdomen and pelvis, usually third week of radiotherapy, the patient can get diarrhea. And immunotherapy related colitis, I'll deal with that in the next slide. Other differentials, we need to rule out infection, subacute obstruction, secondary to the constipation secondary to constipation, GI comorbidities, maybe someone already known to have IBD, previous GI surgery, some medication, malabsorption, or carcinoid syndrome. Then we need to evaluate with history, mainly the stool chart, and about the chemo radio regimen, and when the patient had the last chemo radio. Then examination, all the system examination, investigations, all routine investigations, including stool culture and sensitivity. So general management is mainly stop the chemotherapy or any lactose products. Not the high fiber food, rehydration, small frequent meals. There's a grading, grade 1, 2, 3, and 4 that you can see here. Grade 1 means stool frequency up to 3 per day. Grade 2 means up to 4 per day. Grade 3 means 7 to 9 per day. And grade 4 means more than 10 per day. So usually for grade 1 and 2, we'll start, once we rule out all the infective causes, start on loperamide 4 milligram, followed by 2 milligram after every loose stool. We can go up to 16 milligram per day. If diarrhea is resolved, we can stop the loperamide after 12 hours diarrhea-free interval and normal diet. But for radiotherapy, we need to continue the whole duration. If it's grade 3 or 4 or complicated grade 1 and 2, we need to admit the patient for rehydration, antibiotics if appropriate, then loperamide and codeine. Also, we can consider octreotide or budesonide. If the diarrhea is unresolved, then we can escalate the octreotide dose to 600 microgram per 24 hours, continue IV fluids, review antibiotics, and continue as necessary. Then one of the other important agents we can cause diarrhea is irinotecan. In that, we'll give the loperamide once after first liquid stool, then 2 milligram every 2 hours. If not resolved in 24 hours, we need to consider antibiotic ciprofloxacin. If it's more than 48 hours, patient need admission. The next one is about immunotherapy-related colitis. This also like grade 1, less than 4 stools over the baseline, feeling well. Immunotherapy can be continued unless it's a combination of anti-PD-1 or CTLA-4. Consider all the routine investigations, including stool culture and sensitivity. Then in grade 1 is mainly the symptomatic management with oral fluids and loperamide, and the patient no need to get admitted. And if symptoms persist for more than 14 days, then we need to consider the grade 2. So grade 2 is 4 to 6 stools per day over the baseline, or abdominal pain or blood in stool or nausea or nocturnal episodes. We need to withhold the immunotherapy and discontinue loperamide or codeine because sometimes it can cause colonic dilatation and perforation. So same investigations as before. but there are some additional investigation we need to do here. If it's grade 2 immunotherapy colitis, screen for CMV, viral load, CT cap, and we need to exclude steatoria, that means some malabsorption. Then sigmoidoscopy is indicated, plus or minus biopsy. If symptoms persist more than 3 days or worsens, we need to consider oral prednisolone. No improvement in 72 hours, or worsening or absorption concern, we need to consider grade 3 to 4 management. That's the next slide. So grade 3 to 4 means more than stools per day, or severe abdominal pain, fever, dehydration, blood in stool, and limiting the patient's activities. The patient need hospitalization and isolation until infection excluded, withhold the immunotherapy. So we need to do all the investigation as mentioned before, including sigmoidoscopy. Then early surgical review is needed, daily stool chart, and consider screening for HIV, hepatitis B, hepatitis C, and TB, because the patient may require infliximab. So start on IV methylprednisolone and gastroenterology input. No improvement in 72 hours, we need to consider a dose of infliximab. If there is no perforation, sepsis, TB, hepatitis B, or moderate or severe heart failure. And we can give another repeat infliximab after 2 hours, and sometimes occasionally required. So next one is immune-related pneumonitis. So the grade 1 means radiographic changes only with some non-specific interstitial pneumonia. We need to do all the routine investigations, and here the definitive investigation is HRCT. And we need to consider delaying the immunotherapy, monitor symptoms every 2 to 3 days. And if it's worse, then we need to consider grade 2 or grade 3 to 4. Grade 2 means mild to moderate new symptoms like dyspnea, cough, and chest pain. We can do outpatient monitoring of symptoms daily, and we need to do the investigation as before, plus bloods weekly. Withhold the immunotherapy, start antibiotics only with suspicious of infection, like if there is raised inflammatory markers, temperature. If no improvement after 48 hours, we need to add oral prednisolone. And once resolved, we can wean off the steroid dose. If it's no improvement after 48 hours of oral prednisolone, manage as grade 3. So grade 3 or 4 means new or worsening hypoxia, life-threatening like difficulty in breathing, ARDS. Permanently discontinue the immunotherapy, admit the patient, baseline investigation, initiate on IV methylprednisolone, refer to chest physician, then HRCT plus or minus bronchoscopy, start on empirical antibiotics, and discuss escalation plans about ventilation. Once resolved, we can wean off, as I mentioned before. If there is no improvement or worsening after 48 hours, we need to consider infliximab. And at that time, we need to continue with IV steroids and wean off later on. The next one is about malignancy or cancer of unknown origin pathway. This is sometimes in the wards or when the patient presents to AAU with some non-specific symptoms, and we find the patient has some from the CT scan or from the bloods, we can find, sometimes we find the patient has a cancer or malignancy. So we have done like a pathway. This is mainly to early identify the patient that would benefit from anti-cancer treatment, or to prevent unnecessary investigations in those patients who are unfit for treatment or do not wish to proceed with the treatment. So once we get findings from either the bloods or radiological investigation, we need to take a full history with performance status. Performance status is very important. Then only we can decide about further investigations or management. Then we need to discuss with acute oncology team. So they will guide us through further investigations about, sometimes we need to add few of the tumor markers. As I mentioned here, men with midline or brain mets, we need to add AFP and beta-HCG. The woman with peritoneal or pelvic disease, CA125. If the man with bone metastasis, PSA, and if there is altered bowel habits, CEA or myeloma screen. But once when we discuss with acute oncology team, they can guide us through this. Then staging CG is needed and endoscopy if indicated. Then there is an unknown primary list on eSearch. I don't know any of the juniors know about this. There is like a list that I think on the eSearch we can see that, and we need to refer the patient to that list. So I mean they can further investigate, or they can give us advice. And if needed, we need to refer the patient to the palliative care early as possible. This is just a slide. This is another important point that been that mentioned by the acute oncology team. Um, this is if someone coming with shortness of breath and maybe the referral is like to rule out PE, and we have done a CTP and PE is ruled out, and we'll just discharge the patient. But the team has told me, like, since the patient got the cancer diagnosis, we won't be looking into the other causes. Maybe the patient is having heart failure, maybe the patient is having another infection or a disease progression. So always, if the patient is being referred maybe just for a CTPA, if the CTP is, even if the CTP is negative, we need to consider other diagnoses as well. So these are the differentials for dyspnea. It's mainly either chest infection, it's like a broad one, but I just prepared it just to make sure that there are other things that can be just not only the PE, that also the other things can happen to them. I mean, someone with cancer, maybe anemia, maybe disease progression, maybe it's a drug-induced pneumonitis, maybe it's a superior vena cava obstruction, maybe it's a new diagnosis of cancer or mets or pleural effusion or lymphangitis. Chest pain, we all know we need the patient need an immediate medical assessment. But if sometimes I just want to emphasize on one point, there are few chemotherapy drugs that we need to be careful. The patient can present with chest pain. It's 5-fluorouracil or capecitabine, because this can cause coronary artery spasm. So if someone coming with chest pain and the patient had these chemotherapy drugs, this is one of the differences that we have to keep in mind. And sometimes there are few other chemotherapy medications that can cause heart failure, but it usually won't be an urgent presentation. Usually would be like like a chronic one. We can see the reduction in heart function. Then, as we all do, if P is strongly suspected, we need to risk the CTPA. If the CTPA is not possible, then we need to consider starting on low molecular weight heparin pending the definitive diagnosis, investigation or diagnosis. And other differentials in oncology patients are mainly indigestion, disease progression, or metastasis. So mainly, I know I was a little bit quick because these are all the points that we all know. That's why I just want to remind you. Um, so these are the references. Mainly, you can get like a guideline. It's available on the internet. It's UKONS Acute Oncology Initial Management Guideline. In that, we can see there is like they have mentioned everything like an elaborate manner, what all things we need to do. Then another reference is St. Luke's AUS document. We can get it from online. Then London Cancer Alliance. So I'll be handing over to the acute oncology team next, because they will share their experiences from their practice. Before that, I just want to introduce to my junior colleagues what acute oncology services at Conquest Hospital. We have acute oncology lead here, Dr. Aspasia Soltati. She's a consultant medical oncologist. We have Gemma and Graham Adams. She's acute oncology lead, and our specialist nurse is Hannah Davis. We all know she's very helpful. She always come to AAU, and we used to see her actually. And the way we need to refer the patient to the acute oncology is on the e-searcher, there is a my list, and then we need to refer the patient to the cross-site acute oncology referrals. Then we need to fill in the information. They will contact us, or they will, if needed, they will come and review the patient in person. And just put up here the acute oncology service extension and mobile. I think they don't have a bleep. And there are the resources are available on our extranet. When we go to the micro guide, there is a doctor's handbook which shows then we need to select oncology, and in that we can see the guidelines specifically for each presentations. And recently I found out there is a free mobile app for this UK ONS. It's like we can upload, we can, if we download that app, we can get all the information how to manage each presentation. And thank you. Now I'm handing over to the acute oncology team. I think Hannah would be here.
Hi everyone. Thank you all for attending. I'm not necessarily going to share any case studies, but I wondered, does anyone have any questions? And if you do, please can you put it into the message chat, and hopefully I can answer those questions for you. Okay. So earlier it was mentioned about our referral pathway. So there was discussion about cancer of unknown primary patients. I do note that there is a list which we use for sort of information sharing rather than referrals. So do refer any CUP patients via the usual routes. So it's my lists, acute oncology referrals, and you fill in the details. Regarding timescales, so of the immunotherapy related complications, so this could present after one cycle of treatment, so within 3 to 4 weeks. So for example, colitis, perhaps secondary to immunotherapy, so they could present with increased diarrhea. Complications of immunotherapy, of note, they can present up to 12 months after stopping immunotherapy. So the patient may be on no active treatment, but still present to the emergency departments with symptoms to suggest immunotherapy related adverse events. So do keep an eye out for that. And it is very important to take a clear history from the patient on presentation. Are there any other questions? Thank you very much. And another important factor, like was said in the beginning, is the importance of antibiotics. So the door to needle gold standard time is to be given within 60 minutes. At the moment, I'm doing an audit as part of my work-based learning, and I had a chap present to the emergency department. Unfortunately, he didn't receive his antibiotics until about 205 minutes into his admission. So neutropenic sepsis is a preventable death, and it needs sort of fast sepsis 6 screening, and antibiotics definitely within the first 60 minutes without waiting for the blood results. So thank you all so much for your attention and for attending the session today.
Thank you everyone for your time. Have a good day.